And how we will go about that, I think, will be critically important, even as we move forward on the HIT sign. So let me move to my other 4 pieces of the Implementation Challenge. The What Works Challenge of Comparative Effectiveness Research, which is going to be very much linked to health information management. We have a thematic issue on this topic planned for October. As you know, the Senate bill, which has been adopted now, creates a structure where it will be a sort of a quasi-public, outside the government structure for comparative effectiveness research. And the hope had been to modify that somewhat through the reconciliation provisions, but since it's not clear that that's germane to the budget, we don't know if that's going to actually make it through. So what we kind of know at the moment is there's going to be this independent structure set up, public-private structure to put in place comparative effectiveness research. What is comparative effectiveness research? It's figuring out what the heck we're doing with $2.5 trillion of health spending every year that's working and what's not. It's pretty important stuff. It's not just going to be head-to-head trials of various medications. It's going to be comparing medical interventions with surgical interventions. Ideally, it's going to be comparing public health interventions with other public health interventions. It is going to be the guts of creating an evidence-based U.S. healthcare system, which we have little pieces of, but we're a long way from it. If we don't get this piece right, we are in trouble. We know that we just went through this big debate over whether comparative effectiveness research should ever be used to decide what works in healthcare and then pay for that only. God forbid this country should do something as sensible as that, right? That was going to be, that was the death panels. That was the rationing. That was, we're going to take stuff away from people. We're going to eliminate free choice from healthcare. Well, the way the legislation reads, it is true there's going to be a wall between comparative effectiveness research and coverage decisions by Medicare or anybody else. But if we think for a minute that that should be the case into eternity, we're fooling ourselves. And if we think for a minute that it should be completely walled off, what are we doing? What are we doing as a country? Getting this research done, however, is going to be very, very difficult and expensive probably and hard. And we couldn't set up enough randomized clinical trials to accomplish the gold standard of evidence that everybody wants out of a randomized clinical trial. We're going to have to do things that fall far short of that and that take place far faster and that generate knowledge far faster. Now we have prototypes of how this has happened without us even planning on it happening. For example, I give you the case of Vioxx, where there were early signs from the clinical trials that there might be cardiovascular issues attached to the drug for some people. How did we develop the evidence fast on that? Partly because the large integrated health systems like Kaiser Permanente basically made a decision that they weren't going to give everybody that drug. They were going to have step therapy, but then they were going to follow the results closely for people, the large sample of patients who they had who were going to be on Vioxx or comparable medications, the other NSAID drugs that they would be taking for arthritis or whatever else. Kaiser got some of this early evidence through its electronic health records, some of these early signals that there were the higher rates of heart attacks among the population taking Vioxx. And that was one of the streams of data that got fed into the FDA while the FDA wrestled with what to do about Vioxx and before this decision was made by Merck to pull the drug off the market. So we see the potential now for these observational kinds of studies to have enormous importance in giving us some sense of how we could do comparative effectiveness type research fast and get those results into clinical practice as quickly as possible. But it's going to take a lot of data. It's going to take a lot of linked data systems. It's going to take a lot of ability to interpret data across systems, et cetera, et cetera, et cetera. It is a major implementation challenge. And we have to really agree up front, as I think articles in our thematic issue in October will lay out, what we're going to agree across payers to consider adequate data. Because it's pretty much not going to work if Medicare is holding everybody to one set of standards, whereas private payers are holding people to another set of standards. And another reason this is critically important is if we want to capture what we have in this country, which is an enormous font of innovation, we know that increasingly innovators are going to have to be thinking about comparative effectiveness research as they innovate. They're going to be having to think about how they will show in early stage trials that something that they invent is better than what's out there now and is more cost effective than what's out there now. Because even if the comparative effectiveness research doesn't demand cost effectiveness, the payers are going to demand cost effectiveness evidence. So pulling all that together, huge challenge, and one where the rapid learning cycle is going to be critically important too. We move to a couple of the others. The delivery system reform challenge. We are, as you know, we have all of these provisions in the bill that allow for and pretty much drive forward large-scale pilot projects around medical home, accountable care organizations, bundled payment, et cetera, et cetera. These are some of the secretary's shalls. The secretary's got to get busy and get some of these up and running or decide what to do with some of the things that are already about to be up and running. There's an existing medical home demonstration project about to roll out. Well, do you keep going with that, or do you grow it into a pilot project, which of course is government ease for something much bigger where there aren't as many strings attached, and the Secretary and the HHS and CMS aren't going to have to constantly go back to Congress if they want to change things along the way. All of that has to begin fast. Why does it have to begin fast? Because we've got to, A, bend the curve, as I'll talk about later in health spending, and because if we're really going to provide health care to an enormous large number of people who are going to be coming into the system, we've got to provide it more efficiently than we do now. I give you the case of Massachusetts, which put in place its health reforms. It's now close to 98% coverage in the state. As you know, Massachusetts has more primary care doctors per capita than any state in the union, and they developed a primary care shortage when everybody they moved to universal coverage. What is wrong with this picture? How can you have more doctors per capita in primary care in practice than any state in the union and still have a primary care shortage? Because your system is not organized very efficiently is the answer. Why? Because it's still frozen in time in the 20th century model of visit-based medicine, no reimbursement for anything short of a patient walking into your office and having a visit that he or she may really not need to have and might have been better handled through an email or a phone call or what have you. So all of this has got to happen real fast because in 2014 we start letting lots of more people into Medicaid and into private health insurance. So learning about these models and instituting the learnings as quickly as possible becomes critically important. I think this country is about, maybe at most, a year away of understanding the power of the combined medical home model, team-based medicine, with an HIT, strong HIT support and underpinning, and the potential that has for cost savings. I give you just one of many examples I could cite. Group Health Cooperative, one. Geisinger Health System, another. I was up at Geisinger a few weeks ago. Geisinger, as many of you will know, is a large health system in central Pennsylvania. About a third of the patients served in the system in the Geisinger hospitals and some of the practices that it owns are also in the Geisinger health plan. So about 30% of the Geisinger patient population is also in its health plan, which gives Geisinger the ability to innovate so that if they drive down, conventionally if they were just trying to weed out hospitalizations as a provider system, obviously they would not like that because revenue would go away. But in this case, when revenue goes away on the hospital side, they pick it up on the health plan side. So they have an inherent ability to experiment within this part of their system where they insure the individuals as well as provide care to them. In that piece of their business, they have instituted in many of their practices a medical home model. About 80,000 patients are now in it. Across the board, they have cut rehospitalizations, unnecessary rehospitalizations, that is to say rehospitalizations within a month of a first admission, by 53%. And in some sites, they've cut it by 90%. 90%. And then they've also had a dramatic cut in admissions as well. Now, how long is it going to take the nation's payers to figure out that this is the way that we need to go, right? It shouldn't be a big challenge. How long is it going to take to lure the nation's physicians into these models? That's a challenge. Particularly older physicians who are more set in their ways. I think about my internist. I have an internist who's in his late 50s. His goal is to retire without putting in place an electronic health record. We'll see if he feels that way when the bonuses get announced for 2011, whether he gets a new lease on life as a practitioner and decides to stick with it. Imagining him going into a medical home model where he's not treating his nurse like a serf, where the nurse is the team leader, where he's communicating with me by email. I offered to bribe him a year ago. I said, please, Jack, can I just pay you $100 so you'll communicate with me by email for the year? No way. These are going to be really big, serious changes, but they have to happen, and they have to happen fast. And they're going to be as much cultural issues as there are operational issues. So learning as rapidly as possible, publishing the research of what happens when you have the medical home model, what works, what doesn't work, what works in teams, what doesn't, critically important. And that also has to happen fast. I want to move to the bending the cost curve challenge, which obviously is very closely related. Why is this so important? Well, we know. We know that through the legislation, we just bought ourselves 10 more years of life expectancy for the Hospital Insurance Trust Fund under Medicare. That's a good thing. How do we do that? We bought it by increasing taxes. We're not going to get out of this whole cost conundrum that the nation faces on health care by continuing to raise taxes. We know that. We have got to bend the cost curve. We published an issue devoted to this topic back in September and asked a couple of economists, Mike Chernow of Harvard and David Cutler of Harvard and Richard Hirsch of Michigan, to update an analysis they'd done for us several years ago, which was basically asking the question, if health spending continues to grow at 2 percentage points faster than real gross domestic product, what happens? And if we were able to slam on the brakes and grow it at only 1% faster than real gross domestic product, what happens? Well, the good news is if we are able to slam on the brakes and do what none of us pretend that we know how we will accomplish and grow health spending at only 1% faster than real per capita gross domestic product, good news is that over the next 75 years, only 54% of all the additional economic resources the country generates will go into health care. So that's the good news because it will leave us 46% for everything else. Defense, recreation, leisure, national parks, FBI, terrorism, battling terrorism, fighting wars, whatever else. So that's the good news if we get there. We don't get there if health spending continues to grow 2 percentage points faster than real GDP over the next 75 years. What happens? 119% of the entire increase in the gross domestic product will go into health care, which is a way of saying every additional dollar that the economy generates will go into health care, and then some, because we'll actually suck away resources that we're currently spending on other things and direct them into health care. So imagine the future when 75 years from now, Sasha Obama and Jenna Bush's granddaughter are co-sharing the presidency, and they're flying over the country and looking down, and all they see is the United States of health care, with everything going on in the country revolving around people giving health care or receiving health care. It is not plausible. It is not a plausible scenario. As Herb Stein, the late great economist, used to say,